Recorded. Just so everybody knows, I'm going to turn off my video.
Hey, Brandon.
Hey, Matt, how are you?
Doing well. Good to see you. Thanks for joining us.
Yes. Hey, Cree.
Hi, how's it going?
Westner.
How you doing?
Good, good. How's everything going? I love your hair, by the way.
Thanks. That's going. It's growing.
Hi, this is Jeremy. My computer is telling me that the host is not allowing my video. Does anybody have a thought on that?
Yeah, we are working on it right now, Jeremy. Thank you.
Okay, great.
Well, it's noon. Should we go ahead and get started?
Yeah, let's do it.
All right. Well, good afternoon. My name is Matt Tuburin, he, him, his, Executive Director of the Aliveness Project, a community center for people living with HIV. And welcome to the first ever virtual HIV on the Hill Day. It is inspiring to see so many of you HIV advocates from around the state of Minnesota joining together to push for policies and funding to support people living with HIV and to prevent new HIV infections. It is so important that we talk to our legislators and engage in advocacy. Legislators hear every day from lobbyists, from drug companies, from insurance companies, and other businesses. And if they don't hear from us, they don't know we exist, and they don't think HIV is an issue. It is our responsibility to make our voices heard and make sure that legislators know HIV is a priority. And if we don't do it, no one else will. We know that when we come together and advocate as a community, we are powerful and we can make major changes that will improve lives. We have some exciting legislative initiatives we will be sharing with you today, and we will share easy ways for you to lobby your legislators and make your voices heard. We are also lucky to have some amazing speakers to share with us important efforts to end HIV and the fight for racial equity in HIV care and prevention. This is a collaborative event organized and co-hosted by Minnesota AIDS service organizations, and you'll get an opportunity to hear from them next. And we will start with Just Us Health.
Well, good afternoon, everybody. We're having a little technical difficulty, so I'm sorry that you can't see me right now, but Just Us Health is here and glad to be a partner for this event. Formerly the Minnesota AIDS Project, I think most of you all here know. Just Us Health is a comprehensive HIV/AIDS service and care organization, and we very much believe that HIV is preventable and stoppable, and we're on a mission, along with our partners, to end HIV in Minnesota. I'm especially excited to be here today. Minnesota AIDS Project was the host of AIDS Action Day that many of you participated in, and 25 years ago, when I worked at the Minnesota AIDS Project, had the chance to organize the first AIDS Action Days. And I'm so excited to see how it's evolved over time. But I think one of the things I'm most excited about today is the coalition effort around HIV on the Hill, that it's no one organization's purpose to have a voice at the legislature for HIV, but it's all of our. And working together, we'll be able to have a stronger voice. We'll be able to engage and organize more people. There's no one HIV organization that can do it all. And by working together, we will end HIV. And by working together, we will ensure that our elected officials understand and employ their role that they can play in that. So Just Us Health is glad to be here today. We're excited about the issues that we'll work on in the legislature today. And to turn ideas into laws, we'll need all of your help. So really glad that so many people have joined us today.
Great, I can jump in. This is Phoebe. I am also having a camera problem. I think it won't let me share, so I'm here, but I can see some of you. So I am very excited to be joining this group today. Clare Housing provides housing with support services and nursing services to people living with HIV or AIDS. And we really believe that housing is healthcare. And over the past 30 years, we've been able to expand our services. And the thing that's most sort of poignant for us now is that we're just not keeping up with the demand, and there's more people acquiring HIV and in unsafe housing and without access to affordable, desirable housing. And so that's our main focus, but we are so fortunate to have this strong network of providers and to have a multitude of different legislative issues to talk about and support and get behind. And we're currently serving over 250 people within our housing units, and we have close to 400 on our waiting list. So that's really the motivator for me and what we're doing. And thank you all so much for being here.
Since Gwen's not here, I can jump in next. I see Youth and AIDS projects on the roster next. I'm very excited to be here and echo what my counterparts have said. The Youth and AIDS projects, we provide case management and HIV testing services and treatment adherence and support groups for young people between the ages of 13 to 30. I'm very excited to see what the panel, or hear what the panelist has to say. Hey, Cree, our YAC representative, very proud of all the work that he is doing. I'm just excited to continue to strengthen partnerships with our community agencies. Thank you.
I'm going to just jump in. This is Mary McCarthy. Since we're doing round robins and follow Val. Welcome, everybody. Thank you so much for joining us. Good afternoon. We're hoping that the sun would be out with us today, but apparently that's not the case. I'm with the Rural AIDS Action Network. I'm the executive director, and RAN is an organization that also works with people living with HIV and AIDS or at risk of HIV. We serve folks in greater Minnesota and really like to reinforce that we are dealing with all of the same issues in greater Minnesota that folks are in the metro area. The exception being we don't have the same population base or other robust agencies that are doing this work. And so a lot of the people that we serve really don't have much of a voice, don't often feel like they're able to talk about the concerns that they have or the issues that we address. And so we work actively to advocate on their behalf. And I really appreciate the effort that has been put into putting this event together. And I hope that we can all be an ongoing resource as we move forward, particularly for legislators and other community members that may not have as much information about the services that all of our organizations provide. And I just want to put in a special plug for harm reduction and really talking about those that are at risk of acquiring HIV, which is just as important a population for us to be looking at serving as those that are living with HIV.
Thank you, Mary. This is Bill Tiedemann, Executive Director of Hope House of St. Croix Valley. Welcome, everybody. I'm very excited to be here as well with the other ASO colleagues and all of our community members. Hope House, for the past 27 years and well into the future, will be serving people living with HIV who can no longer live independently through our foster care facility. And we were very excited to launch our new program, Hope at Home, in 2021, which is a community-based aging in place program serving people aging in the HIV and the LGBT community. So we're also very excited to be here and looking forward to working together with our colleagues on future laws and legislation. And thanks so much. And I'll give it back to Matt.
All right, and I just want to say hello from Gwen Velez, the Executive Director of the African American AIDS Task Force, one of our co-hosts. Unfortunately, she had a conflict arise and so isn't able to join us here today, but definitely she says hi and appreciates all of your being part of this effort. So with that, we are honored to have someone who has been an advocate for the HIV community, the LGBT community for many decades, has really really needs no introduction. So I'm honored that we have Senator Scott Dibble to join us this afternoon. Scott, thanks so much for being here.
Thanks, Matt, and thanks everyone. I'm really happy to be here. Even though here is like here in my house, so it's so odd because I continue to project myself. You know, when I was thinking about this event, I was thinking about standing at a podium in the middle of the rotunda at the Capitol, and forgot that no, I'm just going to be sitting at my dining room table with my little buffet sitting behind me. So I just wanted to share a couple of thoughts today. This is a variation on some comments that I shared when we celebrated the anniversary of the passing the Ryan White Act. I think we came up on I can't remember, was it the 30th or 25th anniversary a few months ago. So I'm here celebrating what happens when determined people under pressure, facing adversity, when it seems like no one cares and no one is coming to help, come together to support and care for one another, and to mount a movement of fierce and joyous determination so that our government, our democracy, and every other system that should have responded does do that, in fact. To center us, though, first, I'd like to just remember those who gave their lives, literally, working so hard in the previous years, building the institutions that are represented here today, the organizations, the programs, the services, the philosophies, when no one else was stepping up. For me, these were many of my friends, my mentors, people who are responsible for the kind of person I am today. I remember in particular Keith Gann, Perry Tilleris, Mick Flanagan, Carlton Hogan, Bruce Brockway, Jim Shallgren, and many, many more. And I'd like to invite folks, I'm not sure if, I think everyone has access to the chat. Hopefully you do, and if you do, it'd be wonderful to drop a name or a small tribute to folks who have been your inspiration and hero, who's passed before us, on whose shoulders we stand. I found these words from Carlton Hogan, who was a good friend of mine, one of the forerunners and founders and fierce advocates of the Aliveness Project. And they just so perfectly embody that fierce determination to live a life of dignity and self-determination and to challenge the establishment. He said, let's face it, problem patients often live longer. We may not make a lot of friends in the medical establishment, although it is heartening how many doctors and nurses are beginning to recognize self-empowerment for the positive life force it is. But hey, if making friends were our main objective, I'm sure we could find better places than hospitals anyway. Problem patients have very strong opinions about what is in their best interest. And while willing to listen to reasonable alternatives, are tremendously stubborn when they feel it necessary. So Carlton was Native American. He was a straight guy. And so he was also fond of saying, I'm a straight man and homophobia is killing me. I just remember him hearing him say that all the time. People with HIV and AIDS, already living at the margins of our society, were pushed even farther, losing jobs and their health insurance, unable to purchase insurance on the private market, having been redlined, shunned, ostracized from families and communities, blamed for their own illnesses and deaths. Pharmaceutical companies who either took no interest or priced gouge at war profiteering levels medicines that were ultimately toxic. People rose up, formed alliances and coalitions across differences, and created great organizations and facilities like the ones that are represented here today, whom we heard from before. A few brave doctors and other providers made caring for those with HIV and AIDS their focus. Leaders at the Red Door and other public health clinics made that front door a welcoming place for those who had no other place to go, who were fearing stigma and mistreatment at their own home clinics. And now, with the advent, of course, of highly effective treatment, HIV and AIDS has become what some would call a chronic but manageable illness. And as such, the level of focus and engagement has dropped off dramatically, I won't lie. but the movement continues and must be sustained until HIV and AIDS has been wiped off the face of this earth, and until we recognize that healthcare is unquestionably a human right. Plagues and pandemics no longer target the most vulnerable and the most marginalized, and until we have a public health structure that keeps us as safe and healthy as possible and effectively swings into action, this movement must be sustained. Challenges remain, stigma and discrimination are still with us. People are still losing jobs, housing, insurance, care, and even their families. Just a few months ago, in a very secretive and opaque process, a state agency here in Minnesota sought to eliminate access to certain HIV and AIDS medications to those who are on Medicaid and in the ADAP program for economic reasons only. The community rose up and put a stop to that, but only temporarily. I have a bill that would create that change on a permanent basis and revamp any process that could occur and continue out of sight, out of scrutiny, and with no collaboration. Motivating actions like that, of course, is the fact that the pharmaceutical companies still behave like war profiteers, marking up HIV/AIDS preventions and treatments literally thousands of times over their own development and manufacturing costs because they can, and because people are desperate and unable to survive without these medications. I am also here to uphold and celebrate the fact that Hennepin County, the city of Minneapolis, the state of Minnesota have officially adopted a policy, legislatively mandated in the case of the state of Minnesota, to end HIV/AIDS. We still have 300 new HIV infections per year in Minnesota, and a number that hasn't actually changed at all in literally decades. Far too many people are still walking around unaware of their HIV status, and far too many have insurmountable barriers to prevent them from receiving the kind of sustaining care that also allows them to avoid transmitting to others. I commend the amazing work of those in the community and in the array of state and local agencies committed to and working hard on this vision. But we have a lot to do to build the political will and to align the appropriate policies and resources to achieve it. So along the way, we're going to have to be those problem patients that Carlton talked about. So in the spirit of those brave souls, their families, their allies and friends who stood up to those who had kicked them out of jobs, who continue to stand up out of jobs, homes, communities, schools, families, let's celebrate how far we've come, how much our movement has affected, how we think about healthcare, public health, self-determination, dignity, and justice. But also let's think about how the work continues, but always with that sense of joy and that awesome privilege, knowing that we are a part of something that's bigger than ourselves in advancing the great cause of human progress. So thank you so much. I will stick around for the rest of this program to talk specifically about some of the legislation and respond to questions that people might have. Thank you very much.
Wonderful. Thank you so much, Scott. And I can't get my video back on, but thank you so much. That's an incredibly powerful message. And so if you're willing to hang on for a little bit longer, we can sort of start talking about some of the bills, and it'd be great to be able to have some questions with you and hear a little bit about what's going on at the session this year. So with that, we can roll into talking about our legislative agenda for 2021. Phil, do you want to kick us off?
Yeah, sure can, Matt. Thanks, and good afternoon, everybody. Excuse me. So Phil Duran, he, him, his, I'm the Director of Advocacy and Research at Just Us Health. And we are probably going to focus on 3 bills. I'll take the first one, Matt will take the other 2. The first bill for our discussion today is in the House, it's known as House File 855, and in the Senate, it's Senate File 340. And if I did this right, I just put a link in the chat to that bill for you to take a look at if you'd like. The bill focuses on medications that are commonly referred to as PEP and PrEP. And while I suspect most people on this call are familiar with those terms, just to make sure that we're on the same page, just very, very briefly. These are similar medications, but are given to different people at different stages to hopefully defeat an HIV infection. So PrEP is short for pre-exposure prophylaxis. And what that means is that if a person who is HIV negative believes that they may be at risk of an HIV infection, they can take PrEP, and it is very effective in reducing their chances of becoming infected. PEP is similar, but it's a little bit, it's given at a different stage. So in other words, a person may feel that in the very short recent past, they were potentially exposed to HIV, and they can take PEP, which is short for post-exposure prophylaxis, and putting that medication in their body very quickly after the possible infection dramatically reduces the chances that the infection will take hold and will keep them HIV negative. So those are the two basic categories of medication that we're talking about. House File 855, Senate File 340 changes some aspects of the law in Minnesota that are hoped to expand the ability of people to access these medications quickly and easily. The one part that's not terribly exciting, but is actually very meaningful is, and this picks up on something that I think Senator Dibble was talking about. When a person has a health condition for which there is treatment like medication that is expensive, insurance companies will often implement a process that's referred to generically as step therapy. And the idea is, before we approve you for coverage for the really expensive medications, you need to go through all of these other steps. You need to try all the other, or at least a lot of the other cheaper medications first, show that they don't work for you, and then we'll get you to the more expensive medication. And obviously, you know, they're trying to reduce their expenses, but what it means for the individual is it's going to take longer to get to the point of being able to get the medication that they actually need. House File 855, Senate File 340 will remove those barriers from PEP and PrEP access. So you would not need to go through step therapy, at least as long as the insurer has approved at least one medication where they waive those requirements entirely. If there's at least one option for you to go right to that, then that would be acceptable. They also don't, it was also remove the requirement for prior authorization or for the insurer companies to say upfront, yes, we will cover this before they actually will accept the claim. But the real guts of this legislation is in terms of expanding access by, in some circumstances, eliminating the need for a person to go to the doctor, go to the clinic and get a prescription in the first place. So what this would do is would authorize pharmacists, not require them, but authorize, invite them to join a program where they get training that is approved by the Minnesota Board of Pharmacy on dispensing PEP and PrEP, and or PrEP. They don't have to do both. And if they go through that training, then in the context of PrEP, for example, an individual could go to a pharmacist, and as long as they can show that they are HIV negative, or they have an HIV test right there, or they at least say that they will get tested later on, it authorizes the pharmacist to dispense a small quantity of PrEP to them. It's a 10-day supply, and 10-day supply of PrEP is great. It's not the end all be all, but the intent here is to give people something, a quick, I don't want to say Band-Aid isn't quite the right word, but it's a bridge from right now. It buys you 10 days to get into the doctor, to get the prescription, and then you can continue with your PrEP from there. But it would allow, but not require, pharmacists who have been trained to dispense that medication. There is a limit in the sense that a person couldn't go through that process more than 6 times in a 2-year period, and there would be a record-keeping requirement involved, so that you've got the opportunity to get in, get that temporary dose, that temporary supply, and then buy some time to get to your actual doctor and get the prescription, at which point then there are no more restrictions. With respect to PEP, similar kind of a situation, that if you fear that you may have been exposed in the recent past, you can go right, and the doctor's out of town, or it's a holiday, you can't get in, whatever it turns out to be, you can go to the pharmacist, and again, assuming that they have gone through the training, the voluntary training through the state, they have the ability to provide you with PEP. And that you can immediately begin taking that in order to defeat the potential HIV infection. So again, the goal is to get you the medications in your hand right away. There is not in the legislation, as I recall it, any kind of restriction on the amount of PEP an individual can get. There's a difference between the two medications. One, PEP is assumed to be something you take for a short period of time to get past the point of where this infection may occur. PrEP is something that a person might be on for an extended period of time. And so for that, it's a more limited quantity up front to get you to the point of being able to get that more long term. This legislation is modeled on a similar bill that has been passed in California with the support of the pharmaceutical regulators there. It seems to be working, and we think that it's time to begin exploring this same kind of opportunity here in Minnesota. Through PEP, through PrEP, we're able to really knock down infections and maybe even stop the epidemic in Minnesota. As I think it was Matt who said earlier, we're kind of stuck at around 300 HIV infections a year and have been for a number of years. If there were more people who had ready access to these medications, we think that number could go down significantly. So that's the intent of the bill, is to get medications in people's hands quickly with as few obstacles and barriers as possible. I'll do one last thing. If you have followed the link that I put in the chat to the bill itself, you can sort of navigate around. It's relatively informative. You can find the House authors. You can click through and find the information about the senators who are on board. What I'm putting into the chat now is just a link to our advocacy page on our website. If you go all the way to the very bottom, you can find a link to the district finder. So if you don't know who is your representative or your senator, you can click there, put in your address. It'll tell you who your senator and your representative are. And there are other links on our page that are just adjacent to that. You can look up the directory. So if it's Senator Smith, you can look, and there's Senator Smith, there's their contact information. You can express your support for these bills directly to them. So I hope that's a helpful introduction to this. And we can take questions later on. Thanks.
All right, thank you, Phil. We have a HIV medication drug heavy HIV agenda in 2021. So there's a couple other bills we want to make you aware of, but we are sort of diving into the weeds of medication management within our healthcare program. So we're going to give you the very high level, and then we're going to give you access to where you can get more information about these bills and these issues. So the next bill we want to talk about is Senate File 349. This is the bill that Senator Dibble was just referring to, that is in response to the move that the DHS Medicaid program had tried to make earlier this fall by putting HIV medications on a prior authorization step therapy list. So in the history of there being HIV medications in Minnesota, Minnesota has never put those medications on a prior auth list. And what would have happened had your advocacy not made a difference? What would have happened is around now, there would be people who are taking HIV medications every day, that it's working for them, they're virally suppressed. They would go to fill their prescription at their pharmacy, and their pharmacist would say, sorry, your medication's no longer covered. You're going to need to work with your doctor to either get put on a different medication or go through a prior authorization process through the Medicaid program. And we know that for many people, those barriers would be a barrier for folks staying on their medications and keeping their being adherent to their regimens. So this bill would codify that there won't be step therapy on HIV medications. There are a number of states throughout the country, including Texas, that have passed similar laws. So this is something that we are hoping to be able to make some movement on this year, and we're having ongoing conversations with DHS around this issue. So they're very, very aware of this and very aware of the HIV community really being very loud about and vocal about this issue earlier this year. And then there's a third medication bill that we're working on. This one's relatively simple, Senate File 346, for people living with HIV on a Minnesota public health care program. They have copays on their HIV medications, which can be barriers, particularly for folks who are choosing between food and their medication, a bus token, or their medication. These copays can really add up and be a big barrier. A couple years ago, Senator Dibble's colleague, Representative Hornstein, was able to get a bill through the House that reduced or eliminated the income caps for the AIDS Drug Assistance Program. What was wonderful about that is that we were able to align the AIDS Drug Assistance Program with the ACA. So what has happened is that there are folks who have slightly higher incomes who don't have to pay HIV copays because the AIDS Drug Assistance Program is picking that up. But for folks on a Minnesota healthcare program, they're still required to pay a copay because the Minnesota healthcare program requires copays. So we are trying to work to eliminate that barrier. So that's one of the bills to do that. And then a couple other important points. This year is a budget year. So budget years are always really important that we keep an eye on and advocate for the importance of HIV funding, both for care and prevention. And comprehensive sex education just got a hearing and passed out of its first education committee in the House a week or two ago. So that's very, very exciting, and a bill that this community has been advocating on for a very long time. And then also the conversion therapy ban bill, which again is another issue that Senator Dibble has been leading on and something that we've been pushing for a number of years here as well. So there's a number of other items: housing, hunger, and a number of other LGBT issues as well that we have on our collective agendas that we will be directing you to for more information. So with that, want to go to the next part of our agenda, and we are really excited to have Brandon Alkery joining us today, who has just a really powerful story and something that just really inspires me. Brandon is running for the 4th Congressional District for the University of Minnesota Board of Regents. And I knew very little about this process until learning it from Brandon. And so he's here to tell you about what he's doing and how you can help support him, because every legislator will vote on a nominee for the Minnesota Board of Regents. So your legislator will be voting for or against Brandon, who's a candidate for the Board of Regents. And so Brandon, if you are available, would love to have you introduce yourself to the group today.
Thank you, Matt. Yeah, my name is Brandon Alkery, and I'm actually, it is the 4th District Regent, but they are doing their vote tonight, actually at 5 o'clock. So it's a seat that, if you're familiar with the Regents, they are the governing body for the University of Minnesota system. It's our state college. And what the Regents do is just oversee policies, oversee a lot of the curriculum, approving curriculum. I know a big push for my campaign is to look at diversification, a lot of access and a lot of transparency. If I were to be seated on this board, I would be the first Native American to actually hold this position, which is kind of crazy. given the fact that we have 11 tribal nations and a very robust Native American grouping within the Twin Cities. So I'm excited. As far my connection to the work here, though, I am a member of the LGBTQ community. My partner and I have been together for close to 20 years. We have 3 kids together. I was very excited when I started hearing a lot about the work, and I, full disclosure, I used to work at Minnesota AIDS Project within their housing department. So I was able to actually see the effects of HIV on communities of color in particular, because a lot of my clients were communities of color, and how just without the Minnesota AIDS Project in place and organizations like it, because there are many robust organizations on this call that do amazing things for our community. But without organizations like that, a lot of people would be in trouble right now, given the horrific effects of HIV. So I'm so particularly proud to be part of the work in my short time at the Minnesota AIDS Project, which is now Just Us Health. And I continue to be a voice for communities of color, particularly Native American communities, but all communities of color. And I'm open to having a conversation about what that looks like and how I can be of help in this battle against HIV. So with that, I will turn it back over to you, Matt.
Wonderful. Thank you so much, Brandon. And we're going to have a link where folks can be able to email their legislator in support of your candidacy today. So best of luck on the vote tonight. Do you know, is it the committee vote or is it the full?
It's the joint session tonight. And then they will put forth, right now there's 11 of us going into this, the vote. And tonight, after tonight, there will be 4 people. So, but thank you, everyone.
Thank you. Next up, Mariah Wilberg and Plan to End HIV. Thank you so much, Mariah.
Thank you, Matt. Hi, everyone. My name is Mariah Wilberg, and I use she, her, hers pronouns. I have been living with HIV since 2006. Living with an AIDS diagnosis since 2012. And as I like to say, I have been thriving with HIV since 2013. That's when I left incarceration and came home to the welcoming arms of the HIV community. All of you, you all helped me get back on my feet, accept my diagnosis, and channel my pain into purpose. My current role is leading the implementation of our statewide plan to end HIV and HIV-MN in partnership with all of the leaders and advocates who just spoke, all of our community-based and culturally specific organizations, health and social service providers, community and faith leaders, and every other person who has a role to play in ending HIV in Minnesota. I'd like to start off by thanking Senator Dibble for sponsoring the HIV strategy legislation that made our statewide plan possible, and thank all of my fellow public servants in the legislature for the work they do. I'd also like to thank all of the folks who spoke before me. Thank you for your work and leadership in ending HIV. And I want to thank you all, everyone who is here listening, for showing up and making your voices heard. Well, not really right now because you're on mute, but you know what I mean. HIV doesn't discriminate, but our systems still do. That's why our statewide plan calls for us to identify and dismantle the structural and social barriers that are leading to unequal outcomes. We are not okay with the status quo. We are not okay with the fact that HIV doesn't impact all people and communities equally. We cannot fix systems that are perpetuating inequities until directly impacted people are centered in the policy making, decision making, and budget making that affects their lives, that affects our lives. That's why End HIV-MN calls for the meaningful inclusion of people and communities most impacted by HIV. Ending HIV requires trust, transparency, and accountability between public servants and the communities we serve. We know we have the tools we need to prevent new infections. PrEP is highly effective when taken daily. We will meet and exceed our statewide goals to reduce new HIV diagnoses if everyone who needed PrEP could easily access it. HIV treatment allows people living with HIV to become undetectable, stay healthy, and achieve their best health. Being undetectable also means HIV can't be transmitted through sex. There is zero risk. HIV treatment is also HIV prevention. There are new long-acting prevention and treatment options coming down the pipeline. These new delivery methods have even more potential to help us see an end to HIV, especially for folks with barriers to adherence or privacy concerns. But too many of the people who need them most don't know about these life-changing advancements in HIV science. Too many of our youth don't have the knowledge they need about HIV, sexually transmitted infections, consent, and sexual well-being. That's why End HIV MN calls for us to support comprehensive sex education in public schools and beyond. Too many of the people who need them don't have equal access to these medications and advancements. We see stark, ongoing, institutionalized disparities among our most vulnerable communities. We can do better, Minnesota. That's why End HIV MN calls for us to eliminate these HIV-related health disparities and achieve health equity. To do this, we must address the social determinants of health and barriers to care that are in the way. One of these social determinants of health and an area of great need is housing. We cannot expect people who are living outside, people who are unstably housed, to achieve their best health until they have a safe, warm, stable place to call home. We know that housing is healthcare. We know that people who are stably housed are much more likely to be connected to and retained in the HIV care and have undetectable viral loads. Or for people who are vulnerable to HIV, they're much more likely to access PrEP or syringe services or other prevention options and services that they need. There's a lot of work to do, but I feel confident seeing you all here today. I am proud to stand alongside the community that I know and love. We've done amazing things together, like create our statewide plan, but our work is not done. Our work will not be done until we see equal access to prevention, care, and treatment options. Our work will not be done until we see equal outcomes for all Black, Brown, and Indigenous communities, other people of color, immigrant communities, LGBTQ communities, people who use drugs, people who are homeless, people who are incarcerated, people who are struggling with their mental health. Everyone deserves equal access to the care and services they need to live their best lives. We have spent the last year talking about health as a global challenge with the current pandemic. HIV is still a global challenge, and I'm up for this fight to end HIV, and I know that you are too. As a fellow member of the HIV community and from my professional role, I thank you for allowing me to serve you in the work I do with End HIV MN. We each have a role to play, and I look forward to continuing the work to end HIV in partnership with you all. Back to you, Matt.
Thank you, Mariah. We're incredibly lucky to have your leadership and advocacy in the state of Minnesota. And it's just amazing to call you a partner in this work. So thank you so much for being a part of this with us today. And speaking of amazing advocates and leaders, for the few of you on this call who don't know, Cree is an amazing HIV advocate and youth worker with the Youth and AIDS Project. And look forward to hearing about a lot of the amazing work Cree is doing with others in the state to ensure that folks of color are getting the HIV care and prevention services that they most need and to fight disparities in HIV care and prevention in Minnesota. So with that, thank you so much, Cree.
Yes, hi everyone. My name is Cree Gordon and I am the HIV prevention coordinator at the University of Minnesota Youth and AIDS Projects. I also serve as the co-chair of the Minnesota Council for HIV Care and Prevention. I sit on the Minneapolis Fast Track Cities Initiative. I help Mariah do all of her stuff. But for today, you can call me Harriet because in another role that I serve as Harriet of the Underground Railroad. And for those of you who are unfamiliar with the African American MSM, Black MSM Underground Railroad, the Underground Railroad for short. We are a collective of frontline staff who started meeting in early 2018 when we realized that a lot of organizations were funded to do HIV testing in the Black MSM community, but and while we all got funding to hire testers and do testing, none of us really had the resources to create the events or the community events, create the community to promote HIV testing for Black MSM. And so what we did was the frontline staff, without our agency leaders, without the leaders of our, like the leadership from our funders, we decided to basically get together and talk smack, right? Like how are we supposed to execute testing and preventative measures when so much of our community centers around just that, building and creating community. So we built a community amongst frontline staff who were charged to execute this. And we decided to put our pennies together and make $1. And so we tried to throw events and things together. And so we, with the help of, you know, our supporters at the Minnesota Department of Health, who helped us out when we needed to, we've been able to throw events and do community engagement, centering testing, but well, centering the community and then offering the testing as a secondary piece. Many of our agencies have throughout the couple years we've partnered to throw big events like our Halloween parties. We've also partnered to do smaller events to share testing knowledge and numbers. And as such, since we're all charged to do HIV testing for a very small population of Minnesotans, but we're required to do a lot of testing for them. But like Mariah, I am someone who is living with HIV. I've been living with HIV since 2005. I was diagnosed as a 19-year-old homeless youth and sex worker. And at the time when I looked around, I didn't really see many people like me doing the work. And so I decided to educate myself, and in doing so, I decided to educate others. But in getting into and my charge today is really to talk about racial equity and what we can do around race and HIV. And it is a laundry list of things that we must accomplish first before we can even tackle some of the needs that people living with HIV have. And like I'll be echoing a lot of what Senator Dibble said, what Mariah said, and what many of the other folks on this call said. And while we are focusing a lot on the legislation that would get us access to the medical interventions that can either prolong people's lives of the people who are living with HIV or prevent HIV infections in the case of PrEP, we really have to, like everything else in our lives are intersectional. And so we really, in order to get the communities of color, to get Black communities, Latin communities, Native communities. I mean, Mary McCartney would probably even argue to get rural folks. There is a lot of other issues that need to be addressed before we can begin talking about those sort of things. So, one of the things that we we need to do is within the structure of our government and its systems, we really need to be creating policy to support affordable and low income housing for people living with HIV, right? Like, I mean, point blank period, we know that if basic needs are met, people living with HIV can then center their health concerns. So affordable, creating policy to tackle the issues of affordable housing. Also, we need to be like on the national stage, we need to be addressing the issues of livable wages. And the thing is, $15 an hour would have been great 10 years ago, but we need to be discussing how we're even better than that in the state of Minnesota to ensure that people have the resources that they need, right? We need to talk about access to quality education. And I'm not just talking about education around HIV, but I'm talking about education, like early childhood education, primary and elementary education, secondary education, and university level education. One of the big things Mariah brought up that we've been tackling the coronavirus over the last year, who is it affecting the most? People of color, people who live in poverty, people who live in more rural areas, right? So we also need to be talking about, encouraging STEM programs early on for youth and having more doctors of color and doctors who understand issues of all folks, right? We need to be talking, in order to end HIV in Black communities, some of the things that we need to do is also talk about ending the prison industrial complex, right? And ending that school to prison pipeline that is so real, especially for Black and Latinx folks. And we need our judiciary, so our judges, to be interpreting the law equally for all folks who enter courtrooms, right? We know that Black and Latinx people tend to get harsher sentences than, their white counterparts. We also need to be talking about access, to quality and affordable healthcare at an affordable rate. And I'm a big proponent of advocating for universal healthcare because I feel like, healthcare is a right. And we need our HIV agencies and clinics to also give up ego and hero complexes, understand that we are holistic creatures, don't tokenize, Black, Indigenous, and other people of color and pigeonhole us into just frontline staffs that were built for, our race, our gender identity, or our sexual orientation. And I'm getting the warning that I only got a couple seconds left to talk. But while I got the mic, can we also address, racism within LGBTQI spaces and the fetishization of Black bodies or the dismissal of them? Because within queer community, there is a lot of racism. And can we also address the murdering of Black trans women and get them the help and the support that they need? And I think my seconds and 5 minutes is up, and I'll answer some more questions during the Q&A.
Thank you, Cree. Obviously, 1 hour was not enough time to cover everything that we need to cover. So I think there'll be parts 2s and 3s coming in the future. We will move on to Alex Palacios, who's going to talk about how you can get involved and get engaged. We'll do a quick closeout, and then for folks who are able to hang out a little bit longer, we'll stick around and do Q&A for folks who want to stick around and do that. So, Alex, you're up next.
Thanks, Matt, and thanks everyone for being here. We are so excited to have you all join us. We are so thrilled to have your questions and to have the passion of all of our panelists. But you've been armed with the knowledge, hopefully that is required for you to be an advocate as well. And we have some great ways in which you can do so. And soon here, you'll see a video that will show a lobby sign up form. What is this for? This will be a great way to connect with staff who will set up a lobbying session so that you can speak to your legislators about these things that are important to you. This is a great way to either hold your legislators accountable, provide ideas, feedback, and we'll be happy to set that up. And bear with us for a moment here. It's a pretty simple form. So as you can see, it'll ask for your name and email, as well as an address. And then we will work with you to set that up. The other form is our Help Us End HIV in Minnesota form. And so this is a little more complex, but if you don't have the time to meet with your legislator, this is a great option for you as well. Please feel free to fill this out. It does ask for just a little bit more information, but you'll notice at the bottom that there is a pre-filled email. This will mean that you can contact your legislator simply by filling out this form, and that email will be forwarded to them. Great and easy ways to be part of the change. Thank you.
Well, this is Jeremy Hansen Willis again with Just Us Health. I want to thank everyone for joining us today. I want to especially thank the speakers for sharing all of your wisdom and insight and passion and the leadership that you provide in our community. To all of you who have gathered today, we hope that after this event that you'll be a little bit more informed and a little bit more motivated to reach out to your legislators about these important issues. Without your voice, these ideas will only be ideas and will never become law. By adding your voice, we can ensure that these ideas actually become law. Now, the bills that we talked about today are relevant and realistic in the legislature, and if they become law, will help us to end HIV. So we really need your help and your voice to ensure that the legislation we've talked about today is not only introduced, but heard in committee, gets voted, and signed by the governor. These bills are important and will help us to end HIV, but as has been noted, our broader legislative agenda also recognizes that ending HIV cannot be achieved until the brutality of racism is broken and the experience of Black people, Indigenous people, and other people of color are centered and amplified. And so please take a look at the broader legislative agenda that we and our allied organizations are working on together to have an agenda of advocacy and policy and legislation that responds to real people's lives. As Chris said earlier, and others, ending HIV must respond to the reality of people's lives and respond to the multiple factors that put people at risk for HIV and other health issues. HIV is a disease of injustice and must be met with justice, not just charity. So thank you all for standing up to be a voice for justice. Help us turn these bills into law and help us ensure that the full advocacy agenda that we put together that responds to the reality of people's lives and the racism that we face every day is also the center of our work. Thank you again for your time. And now I think we will open it up to questions that people have.
Hello, everyone. My name is Dylan Boyer, and it looks like we do have some questions in the Q&A to all of our attendees. If you do have a question for one of our panelists, please put it in the Q&A and we will reach out to somebody to answer them. Phil, these first couple questions go out to you. I think talking about PrEP and PEP accessibility. One of the questions reads, the California law allows 30 days of PrEP. Why is this bill written for no more than a 10-day supply for PrEP? If you want to give an answer to that.
No, thank you for that. I appreciate that. I'd have to go back and double check the California legislature because we modeled it on their bill. If they allow for 30, that's fantastic. We've heard some feedback that that would be preferable to 10. Yeah, I mean, we can certainly take a look at that. The other question is what will be politically doable in Minnesota? Plainly, what's doable in California is not what's doable in St. Paul. Senator Dibble can speak very powerfully to that one. We probably have a more receptive audience in the House, and we may have more challenges in the Senate. And so it may very well be the political calculation is really involved in trimming that back to a 10-day supply so that folks can then get into their physician for the prescribed ongoing care that they're looking for.
Great. And we do, Phil, I'll keep you on. We have one other question about PrEP and PEP laws. Is there any inclusion that requires insurance plans to cover the medications provided by the pharmacist?
Yep, if you follow the link that I put in the chat earlier to House File 855, Senate File 340, if you look at the bill, Section 2 of the bill specifically does address that and requires that that insurers cover them as they would others. It's also helpful to clarify that I think I said earlier, there's a limit on the number of visits you can do, 6 over a 2-year period. And that's not entirely true. What the limit is on insurance coverage of those kinds of visits. So insurers are not required to cover anything more than 6 visits in a 2-year period. And just given the cost of PrEP, it effectively makes it very expensive then to go back for number 7 if you're not going to be billing that to insurance. So it effectively comes down to a 6-day or a 6-visit restriction.
Thank you for all of that. It looks like we have another questions about what can we do to get providers to test for HIV at annual exams? Maybe this can go out to Mary. I think that might be a good question for you. Maybe some experience that happens out in rural Minnesota that they're not being tested for HIV in annual exams.
Gee, thanks, Dylan, for putting me on the spot like that.
No problem, Mary.
I think there's a variety of issues, and I would just go a little bit further to say that I also, along with some other folks that are on the call today, participate in the FEMOR committee, which is the Fetal Infant Mortality Review. And we've also seen things like congenital syphilis increasing and things like that. I think a big part of it, y'all have touched on it a lot, is reducing stigma. We have a lot of folks, particularly those that are at risk of being HIV positive, that may not know their status, who may not engage in healthcare at all because of experiences they've had in the past with providers. We also have some incredibly amazing providers out there that folks may just not know about or know how to access. So I think a lot of it is ongoing conversation and normalization of HIV and other STI testing in routine medical settings, and continuing to work with providers at every level we can to ensure that they're providing good, competent, quality healthcare and not creating barriers when folks walk in the building.
Great, thank you.
One of the things, can I add to that? This is free. One of the struggles in answering that question is because HIV still remains a opt-in test, right? So in order to get tested annually by your provider, like you'd have to opt into getting HIV testing, but a provider can test you if you have health concerns. A provider can test you for a number of things, without asking, your permission, so that they can figure out what it is that's wrong with you. But HIV is different. And that goes to Mary's point about stigma, is that you have to opt in to an HIV test instead of opting out of testing like you do with a lot of the rest of your medical care. So a way to sort of mitigate that is if, clinics and hospitals and systems start changing in-house their policies around, having HIV be an opt-in test and have it, be opt-out like everything else. And I think that is where you can potentially see. So advocating for it at your clinic or clinics that you know of could be a way finding some of those, infections or doing some more of those testing at annual physicals or annual things. So that's one of the biggest problems, is that HIV is still an opt-in test.
Thank you for that input, Cree. And it looks like we have some people signing off, and we are 3 minutes over. I am going to ask one more question, though, to Mariah and Cree and whoever else wants to answer it. It looks like we got one more in that says, what can Minnesota health plans do to assist HIV positive and HIV at-risk BIPOC populations? Mariah or Cree or anybody else who wants to jump in on the work for Minnesota health plans.
I can speak a little bit to program HH and ADAP, which is the AIDS Drug Assistance Program, and something that we are doing to ensure that we are better serving BIPOC communities is that we are working on consulting, initiating some consulting with culturally specific organizations to take a deep dive into our program materials, websites, policies, and procedures, and give us specific advice on how we can make necessary adaptations or translations or changes to ensure we're better meeting the needs of this community. So we're very excited to be partnering with Sub-Saharan Youth and Family Services to take a deep dive into how we can better meet the needs of Sub-Saharan immigrant communities. And then we are finalizing plans focusing on other communities, and we'll talk about those once they're final.
Thanks, Mariah.
This is Mary. I'd like to just jump in real quick too. I'd like to give a shout out to MDH. Right now, they're funding a program that's a collaborative effort that's SSP linkage. So for anybody that's using a syringe service program, it's a linkage to care. And that care could be anything. It's not necessarily healthcare. It's engaging folks in getting into the system. And we've seen some tremendous successes just getting folks reconnected on minimal levels. And I say minimal only to say that for the overall HIV perspective, it may not be driving them directly to healthcare, but it's at least introducing them to systems and other places where they can get needed support, and hopefully in a good collaborative way, working with the staff that are helping them navigate those systems so that they get more and more comfortable within them and have somebody alongside of them to help them with those tougher situations. So I think as we continue to be creative about how we're delivering service and how we're able to support folks during that process, we hopefully will see a lot better outcomes.
Thanks, Mary. I know that we got a couple of other questions. Unfortunately, we don't have time for all of those questions, but our panelists are available and they can put their contact information in the chat feature now if they would like, so that people can reach out to them directly and ask those questions. And I'm going to turn it over to Matt just to close us out for this afternoon. Thank you.
Thanks for joining us, everybody. Make sure to take action and definitely reach out with any questions or anything we can do to help, and look for more information coming out from organizations about next steps in the process. So thank you very much for joining us on this virtual lobby day. We appreciate it.
Thank you, everyone. Good to see you all.
Thanks, everybody, for having me.